Welcome to the Deep Dive. We're here to give you those essential insights you need and fast. Today is a really focused session, specifically for you orthopedic residents gearing up for those big postgraduate exit exams. Our goal, simple, break down complex topics, make them clear, and hopefully give you a few of those aha moments that really stick. Today, we're tackling a core topic, tibia shaft fractures. And this deep dive, it's drawn directly from the fantastic Ortho Made Simple notes, which you can find over at mokyingren.sg. These notes, just so you know, were created by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, and he successfully went through his FRCS exams back in 2022. So yeah, he's been right where you are now very recently. Okay, let's jump right in. Picture this. Patient comes in, tibia shaft fracture. What's the absolute number one must-not-miss thing flashing in your mind, the first thing you have to rule out?
Oh, absolutely. It's compartment syndrome straight
Yep.
away. It has to be the top priority because missing it, the consequences are severe, truly limb-threatening. We're talking irreversible damage to muscles, nerves, permanent loss of function.
So speed is critical there.
Exactly. It needs immediate recognition, immediate assessment, and, well, rapid surgery if it's confirmed. Everything else, frankly, can wait a moment. This can't.
Okay, critical point established. Compartment syndrome first. So let's say that's assessed or it's being closely watched. We start thinking about surgical fixation, specifically nailing. What's our usual starting point, the standard entry point for the nail?
The standard entry point, the one we typically aim for, is just medial to the lateral tibial spine.
Okay.
That landmark gets you right down the canal, helps you align the nail correctly, and importantly, keeps you away from the crucial structures around the knee joint itself.
Got it. Medial to the lateral tibial spine.
Yeah.
So we've covered those first critical steps. Now let's dive into something that always sparks discussion. Certainly something you need to be sharp on for exams. The whole reaming versus unreaming debate in tibial nailing. This is where things get really interesting, right? What are the main arguments for reamed nailing? Why do surgeons choose to ream?
Well, there's some pretty strong arguments for it.
Yeah.
First, the act of reaming itself, it generates bone debris right at the fracture site.
Like an autograft.
Exactly. It acts like an in situ autologous bone graft. It releases growth factors, provides osteoconductive material, basically kickstarts the biological healing process.
Okay.
Second, reaming lets you put in a bigger nail, a larger diameter nail. And that's not trivial. It means significantly more biomechanical stability, stronger fixation.
Makes sense.
And third, this is a big one, backed by evidence, lower reoperation rates. Studies, particularly the big Bondari sprint trial, have shown this advantage for ream nails. Fewer returns to the OR for things like non-union.
Right. Those are compelling points. But naturally, there's the flip side. Reaming involves, well, disrupting the inside of the bone. What about the blood supply? How does reaming actually affect the tibia's vascularity?
Yes, the blood supply question. That's really the core of the historical concern, isn't it? Normally, the tibia gets its blood supply centrifugally.
Inside out.
Precisely, from the inside out.
Yeah.
The inner two-thirds, roughly, rely on the nutrient artery running down the medullary canal. Now, reaming, it definitely disrupts that intramedullary supply. There's no question about that.
Okay.
But the tibia is quite remarkable. It has this compensatory mechanism. The periosteal blood supply, the vessels on the outside of the bone, immediately ramps up its contribution.
So the outside takes over.
It does. It maintains the cortical blood flow. Reichert described this back in '95. And interestingly, the direction of blood flow actually flips. It becomes centripetal outside in, relying heavily on that periosteal network.
That's fascinating, the reversal of flow.
It is. And if we want to get into the timing, studies like the fractured sheep tibia model have looked at this. They found cortical revascularization, sort of getting back to normal, happens by about 6 weeks in unreamed bone.
6 weeks.
But in the reamed group, it took longer, more like 12 weeks. So there's a definite transient delay in fully restoring that cortical supply after reaming, even with a periosteal backup.
Okay, so there's a biological cost, even if temporary. This brings us right back to the clinical reality. You mentioned the Bondari sprint trial again. Given these biological effects, what did that landmark 2008 trial actually find when comparing reamed versus unreamed nails in patients? This is where the rubber meets the road, right?
Absolutely. The sprint trial was huge. Multi-center, randomized controlled trial, over 1,200 patients, 1,226 to be exact. And they had a really good follow-up, about 93% at 1 year.
Solid data then.
Very solid. Patients got either reamed or unreamed nails. Now, looking at the big picture, overall non-union needing more surgery like implant exchange or bone grafting was pretty low and around 4.6% across the board. And here's the first key point. When they looked at the primary outcome, which was a composite of things like fixation failure or non-union across all patients, all fracture types combined, there was actually no significant difference between the reamed and unreamed groups.
No difference overall. That's interesting.
Right. The relative risk was 0.990, confidence interval crossed 1, so statistically similar outcomes overall. However, and this is the crucial part for you to remember for exams,
Okay.
when they broke it down by fracture type, a very clear pattern emerged. For closed fractures, reamed nailing was significantly better.
Better how?
Fewer primary events. Only 11% in the reamed group compared to 17% in the unreamed group. The relative risk was 0.67 and the p-value was 0.03. That's a statistically significant advantage for reaming in closed tibia fractures.
Wow. Okay. So for closed fractures, reaming wins.
Based on sprint, yes. But now look at open fractures. Here, the trend actually reversed. Ream nails had a higher rate of primary events. The relative risk was 1.27.
Higher. So reaming was worse for open fractures.
Well, the trend pointed that way. But crucially, this difference was not statistically significant. The p-value was 0.16. So you can't definitively say reaming is worse in open fractures based on sprint, but the advantage seen in closed fractures certainly wasn't there. If anything, there was a suggestion of potential harm.
So the practical takeaway.
The practical takeaway for you is huge. In a closed tibia shaft fracture, the evidence strongly supports reaming it significantly reduces the chance of needing further surgery for non-union or fixation failure. For an open fracture, however, that benefit disappears, and there might even be a slight downside, though not statistically proven. So you weigh the potential benefits of a larger nail against the potential further disruption to an already compromised soft tissue envelope. The decision becomes much more nuanced in open fractures.
That's incredibly important context. You're listening to The Deep Dive. And just a reminder, this detailed analysis stems from the Ortho-Made Simple Notes available at mokyingren.sg. Okay, that sprint trial breakdown is vital. Knowing when reaming helps and when it might not. That's key. Let's pivot now to another common challenge. Managing and preventing deformities, especially when the fracture is near the ends of the tibia. Let's start proximally. Proximal tibia shaft fractures. What are the classic deformities we worry about, and why do they happen?
Right, proximal tibia fractures. The two big ones you need to anticipate are valgus,
Angling outwards.
exactly, and procurvatum.
Angling forwards, apex posterior.
Correct. The valgus is mainly due to the pull of the pons and serenus muscles inserting medially. The procurvatum comes from the strong pull of the patellar tendon on the tibial tubercle.
Okay, pes pull for valgus, patellar tendon for procurvatum.
And there's a great little mnemonic to lock this in. I think proximal is procurvatum and valgus helps keep it straight under pressure.
Love a good mnemonic. Proximal is procurvatum and valgus.
Got it. So knowing these forces are acting on the fragment, what tools or techniques, what surgical adjuncts can we use specifically to counteract these deformities in proximal fractures?
We have quite a few tricks up our sleeve. First, using a suprapatellar nailing technique can sometimes offer a better, more inline trajectory, helping control that proximal fragment.
Okay, different entry.
Yes. Also, sometimes a more lateral entry point than standard can help counteract the valgus tendency. Then you have your basic but essential pointed reduction clamps to physically hold the reduction.
Clamps, standard.
Crucially, Poller screws or blocking screws. These are really effective. You place them strategically, typically on the concave side of the potential deformity.
Concave side. So for valgus, you'd put it medially, and for procurvatum, anteriorly on the proximal fragment.
Exactly right. On the concave side, in the proximal fragment, they act like a bumper to guide the nail down the correct path and push the fragment back into alignment, preventing it from drifting into valgus or procurvatum as the nail passes. Clever. What else?
You can also use temporary unicortical plating, just small plates placed on the cortex, sometimes even outside the skin initially, just to hold the reduction while you're getting the nail in. An ephemeral distractor can be incredibly useful, especially if things are shortened or comminuted, to pull things out to length and help with alignment.
Right, distractor for length and gross alignment. Good list. Okay, let's flip to the other end. Distal tibia shaft fractures. What are the typical deformity risks down there?
Distally, the common culprits are varus,
Angling inwards.
yes, and recurvatum,
Angling backwards, apex anterior, opposite of proximal.
correct. Often influenced by the pull of the Achilles tendon and just the effect of gravity on the foot, pulling it down and back.
Okay, varus and recurvatum distally. So what are the corresponding adjuncts we use down there? Similar principles?
Similar principles, yes, but tailored to the distal end. A key one here is often fixing the fibula first.
Stabilize the fibula.
Yeah, if the fibula is also fractured, Plating it restores length and rotation for the whole segment, which indirectly helps align the tibia. Very helpful distally. Again, polar screws are your friend.
Concave side again?
Always concave side, but this time in the distal fragment. So for a varus tendency, you'd place it medially in the distal fragment. For recurvatum, posteriorly.
Got it. Distal fragment focus.
Femoral distractor can be used here too for length and reduction. And again, temporary unicortical plating can help hold those discal pieces, especially if they're small or the bone is tricky.
Makes sense. This brings up a common decision point for distal fractures. Plate or nail? How do you generally decide?
That's a frequent question. It really hinges on how far down the fracture extends towards the ankle joint and maybe the degree of comminution. Nails can go quite distal now.
Right.
For instance, take the Synthes nail system. It has options for 4 distal locking screws, and they're positioned at very specific distances from the tip. 5 millimeters, 13 millimeters, 22, and 37 millimeters.
That's quite precise.
It is. It tells you exactly how much bone you need below the fracture to get good fixation with that specific nail. If your fracture line is, say, only 10 millimeters from the joint, you might still get 2 screws in with that system. But if it's even closer, or heavily smashed up right near the joint, metaphysio-comminution, a plate might give you better purchase and control, especially for reconstructing the joint surface itself.
So proximity to the joint and comminution push you towards a plate.
Generally, yes. And don't forget, for really severe combination, particularly with significant open wounds or soft tissue issues, circular external fixation is also a very important option. Sometimes as definitive treatment, sometimes as a bridge.
Good point about the X-fix. What if the fracture actually goes into the ankle joint? Any special sequencing rules for fixation then?
Absolutely critical rule there. Fix the joint surface first. If you have intra-articular extension, you need to get those articular fragments reduced perfectly and often hold them with screws before you pass the intramedullary nail. Restore the joint congruity, then stabilize the shaft.
Joint first, then nail. Got it. One last quick practical point, dynamization. We sometimes remove a screw later to allow compression. Where are those dynamization screws typically placed?
Dynamization involves allowing controlled axial movement. So the screws involved in static locking that you might remove later are usually placed away from the fracture site, often in a dynamic slot if the nail has one. The idea is to unlock the construct axially, allowing micromotion at the fracture site under weight bearing, which can stimulate callus formation.
Okay, away from the fracture to allow that controlled slide.
Exactly. You maintain rotational control, but allow that little bit of axial compression.
Fantastic. We've really covered the spectrum here on tibia shaft fractures. We started with that absolute immediate priority ruling out compartment syndrome. Then we dove into the reaming debate, unpacking the pros and cons, and crucially, the evidence from the SPRINT trial, especially that key difference between closed and open fractures. We then moved into managing deformities, remembering proximal is procurvatum and valgus, and the opposite risks distally and all the adjuncts like polar screws. And finally, navigating that plate versus nail decision distally, plus important tips like fixing the joint first and understanding dynamization. Hopefully, this gives you a really solid framework.
I think so. And the key thing really isn't just memorizing these facts, but understanding the principles behind them. Why does reaming help biologically? Why do polar screws work? How does the SPRINT trial evidence directly guide your choice for this patient with this fracture type? That deeper understanding is what truly prepares you, not just for exams, but for making sound clinical judgments every day. Think critically about the why.
Excellent final thought. And just to reiterate, this deep dive was grounded in the OrthoMade Simple Notes you can find at mokyingren.sg. Truly a great resource as you continue your preparation. As you keep going on this demanding but honestly incredibly rewarding journey in orthopedics, just remember that every challenge, every complex case is a chance to learn and grow. Keep that curiosity alive. Keep striving for the best for your patients. And perhaps a final thought for reflection from Proverbs chapter 11, verse 5. The righteousness of the blameless keeps his way straight, but the wicked falls by his own wickedness. May your work always be guided by integrity and skill. We wish you all the very best in your exams and in your careers. Keep pushing forward. You've got this.